What is up, everyone? Welcome back to the Critical Care Lounge. I'm here as always with my co-host, Dr. Adam Green. What is up, my friend?
Not much. Episode 7, right? Or am I losing track of count?
This is the lucky number 7. Amazing things will happen on this very podcast today. It's good to have you all here. If you are new to the channel, please go ahead and subscribe to Critical Care now. Like this video. It just helps boost the algorithm. And tell your friends that every 2 weeks we come at you with a new episode where we bring on a new expert and we talk about some of the things that are relevant to your practice. Adam, it's been a little bit of time since we last did one of these. How's everything been with you?
Everything's great, getting hit by another surge and trekking on. How are things with you?
Everything is just about the same. We do this every show, but people probably realize we work at the same hospital. So mi casa es su casa.
So it's silly for me to ask how busy your hospital is what you're saying.
It makes for good banter is what it does. Well, let's go ahead and bring on our guest. Today we have a very, very special guest, but I'm going to let Adam do the introduction honors.
Absolutely.
Under the bus.
Each episode, Haney says, "Don't worry, I'll introduce him this time." And then the last second, he dumps it on me. So today we have Dr. Danielle Behrens. She is the program director of the Heme Fellowship at Cooper. She is a assistant professor of medicine and hematologist extraordinaire. And my favorite thing about Danielle is she shares something in common with Haney and I, and that is a passion for the Poconos.
I thought it was going to be red hair.
No, she too loves the Poconos, just like you and I, and that's unique.
Very nice.
So with that, let's bring her on.
Hey, Danielle.
Hi, guys. Thank you for that wonderful intro. I don't know that I consider myself extraordinaire, but I'm very happy to be here tonight. So thank you for asking.
No, we're absolutely happy to have you. So, today we're going to be talking about tumor lysis syndrome. That's what we've been kind of promoting. And we just wanted to start off by asking you some questions that I think are pretty general, but it can be a confusing topic for people. So just to start off right off the bat, if you could you give us the textbook definition of what tumor lysis syndrome is?
So I was always taught you never use the word in the definition when you're going to explain it to someone, but most of the time you will hear it as a syndrome or a constellation of laboratory abnormalities that you see in patients who have aggressive malignancies. And so for the definition, as many of you may be aware, we see things like hyperkalemia, hyperphosphatemia, renal failure, and then hypocalcemia.
Got it. Okay, perfect. So then let me ask you this. Are there versions of tumor lysis syndrome that you might see that deviate from this? Are there any subtle things that you would think that this is acting like tumor lysis without some of those findings or anything that's classic, or pretty much you see that, you got tumor lysis syndrome?
Once you see those laboratory abnormalities, you need to be concerned about tumor lysis syndrome. The malignancies that are most often associated are going to be the very rapidly proliferating things such as acute leukemias and high-grade lymphomas and also small cell lung cancer. But I've seen it in variations of multiple myeloma, such as the plasmablastic type, and I've also seen it in solid tumor patients who have a very high tumor burden. Tumor lysis typically happens once we initiate chemotherapy, but I've also seen cases of spontaneous tumor lysis where patients present to the hospital feeling unwell. They don't know that they have a diagnosis of a lymphoma or a leukemia, and their first presentation, they're in spontaneous tumor lysis because of the tumor burden and the rapid proliferation and cell death that's occurring.
So I think it's almost as if you have our question sheet and are just going down on your own. But real quick, is there a time when the labs meet criteria for TLS, but it doesn't really matter? Because what it kind of sounds like to me is renal failure with high uric acid levels.
So you do have high uric acid levels as well. Thank you for reminding me. I'm on the spot, so I'm trying to jog my memory. So you do get high uric acid levels as well. Hyperuricemia, though, does not always indicate tumor lysis. So patients can have elevated uric acid levels just from the renal failure alone because our kidneys do excrete uric acid. So, we don't necessarily start treatment immediately just for that lab abnormality. We really need to see it in the setting of a malignancy.
I see. And so you're primarily, I know this, but everyone doesn't. You're primarily an inpatient oncologist. That's correct. And so you get patients admitted all the time to your floor. And how do they usually present that you say, oh, we really need to check tumor lysis labs? Or do you, in fact, just check it on everyone?
So any patient that comes in with a suspicion of high-grade lymphoma, small cell lung cancer, or acute leukemia immediately upon presentation and our evaluation gets tumor lysis labs drawn. Those patients where we see blasts on the peripheral smear, we immediately start treatment before we even have a diagnosis, because we know that we're going to have a diagnosis in the immediate future, and we need to pre-medicate these patients so that when we do start the chemotherapy, they're already hydrated, their uric acid levels are as low as they possibly can be, and we're already kind of flushing their system before the chemotherapy takes over to kill the cells. So the majority of patients, to be honest, that I see on the oncology service are at risk of tumor lysis syndrome by the nature of my job. Being an oncology hospitalist, I run the leukemia and the high-grade lymphoma service. And so many of our patients are coming to Cooper because they don't feel well, and their admitting diagnosis ends up being either a leukemia or a high-grade lymphoma.
I see. So it's, sorry, Annie, I'll get to you. So I think of it as shock to me is just part of being in the ICU. It almost sounds like tumor lysis is just part of your job. That it scares me and Haiti when we see the words, but to you, it's just part of their overall picture.
Yeah, and you know, the comfort level, because we see it so much, is very different than obviously the emergency room providers and the internal medicine providers, and that's why we try, you know, regularly to educate house staff and junior attendings on what to look for, because oftentimes the patients are presenting to the emergency department or being admitted to the medicine service before we hear anything about them. And so recognizing it early is incredibly important so that you can start the appropriate medications and hydration, and also, if necessary, have the consultants on board, because patients may end up on dialysis.
So I have a question that just builds off that, and you answered this partially. You know, you can have patients who present tumor lysis syndrome that are not on chemo, but what would you say the ratio of that is, patients versus chemo, patients on chemo as compared to patients who present in tumor lysis? It sounds like most would be after chemo, less so as a tumor presentation.
Yeah, most are after chemotherapy, and we worry about it most in the first 24 to 72 hours or so, depending on the blast count with our leukemias and depending on the tumor burden with our high-grade lymphomas. And so during that period of time, we aggressively check their labs every 8 hours. We look to give them things like Valtessa to decrease their potassium. We use rasburicase if their uric acid to start is incredibly high. If it's kind of less than about 10 or so, we'll typically do allopurinol sometimes twice a day with hydration to prevent the formation of additional uric acid. And then we aggressively replete their calcium as needed.
Fantastic. So let me build on that and ask you, so I have a patient who I've confirmed that they have tumor lysis syndrome. And I wasn't prepared. I didn't hydrate them before. I didn't know that they were coming in. They just sort of appeared. So what is your step-by-step approach to managing that patient? I call you from the ICU. I say, this person's really sick. Their potassium is elevated. I'm going to do the usual things, but what would be your recommendation from a consultant oncologist point of view for me?
Well, you know, the normal critical care things that you would do that we've discussed, so aggressive hydration, which at times can lead to volume overload and respiratory failure. You know, making sure that we correct the hyperkalemia, the hyperuricemia, the hyperphosphatemia, and the hypocalcemia to prevent cardiac arrhythmias, and worsening of renal failure due to either crystal deposits of the calcium phosphate or the uric acid in the kidneys. Consulting nephrology and monitoring their urine output, because we need to know if they're becoming oliguric or anuric, and if we need to initiate dialysis. And then also just a good history and physical if we're not physically present in the building, so we can understand, is this a patient that's coming in with a large mass in the chest? Do they have palpable adenopathy? Do they have a CBC that shows a white blood cell count of 300,000? Because those are indications where we're going to be coming into the hospital to help evaluate and get started on treatment.
Fantastic. I'm going to turn it over to Adam. I just want to remind everyone in the audience, if you have any questions, please drop them in the comments. And then when we get to our Q&A session, we can just hit Dr. Behrens up with some stuff. Adam.
Yeah, I just find it so fascinating because I'm sitting here listening to what you're saying about tumor lysis, acute kidney injury, the cancer patient, and it is so easy to get confused. So I'm assuming the uric acid itself isn't harmful per se, but rather it's a marker of how severe the tumor lysis is, or does it itself directly cause renal failure?
Well, it can directly cause renal failure by precipitating in the kidneys. And so we use rasburicase, which is the only medication that can make uric acid soluble into allantoin. And so we use allopurinol to prevent the formation, but if your uric acid is high enough, the only medication we have available to help solubilize that and help you excrete it is going to be the rasburicase. We have gatekeepers of rasburicase at our hospital. I'm sure other people do as well, because it is a very expensive medication and it's not indicated for every single patient. So, we work with our pharmacy in order to give that medication. The typical dose is about 3 milligrams, but we can give 1.5 and see dramatic responses. And so we typically start with a lower dose if we do need it, and then we monitor the labs afterwards. And if we do need to give more in the future, we'll give a second dose.
Yeah, that was always the easiest for me when I was on my heme floor, because it was the only medication I could remember. I could not remember any of the chemotherapy, but uricase was just made sense. So that's all I got from that.
When you take the Scrabble box or boggle and you shake it up and throw it on the table, that'll be your next chemo drug. Just all letters thrown together.
And so that's great. You get, and I know you know this, but I'm assuming you get hyperkalemia, not just from the renal failure, but also from the tumor cells dying from the chemotherapy you're giving.
Correct. So you get intracellular release of potassium. So as the cells die, they release their intracellular contents into the bloodstream. And so that's where you get your hyperphosphatemia and your hyperkalemia and your hyperuricemia. The calcium drops because it precipitates with the phosphate and can cause calcium phosphate crystals as well in the kidneys, which can worsen the renal failure.
And just to give people listening some appreciation for just how bad this can be, how fast can you see someone go from like, oh yeah, I think they might be in tumor lysis syndrome, into like we're getting EKG abnormalities with the hyperkalemia, we have to start stat dialysis. Can you give us a sense of just how quickly that can happen?
I mean, I've seen it in hours, especially and I've been doing this a long time, so in the decade that I've been doing it, I've seen people in hours end up ventilated and on dialysis. And those patients are typically patients who come in with acute leukemias with very high white blood cell counts. They already had some renal insufficiency to begin with, partly because they weren't feeling well, and so their PO intake at home was not great. And then in addition, they have a really high tumor burden that is just spontaneously dying on a regular basis.
Let me ask you a little bit more of a granular question, but when we're studying this or taking our boards, right, we look at low, medium, and high risk patients. Does it really matter, or once you've identified them, it's a full court press for everybody because there's always that potential for them to progress very quickly?
I think clinically speaking, there's a lot to be said for the gestalt, I guess you could call it. When you have young patients that have healthy kidneys and really minimal medical problems, they tend to be more resilient. You still treat them aggressively, but they tend to be a little bit more resilient to the insult. When you have patients who are older, who have underlying medical conditions, you tend to see them deteriorate a little bit faster because their reserve is not there. They love to ask on the boards things like low, medium, and high. At the end of the day, I don't think it really matters. I think what you want to do is what's best for the patient to preserve their organ function and prevent yourself from being in a situation where the patient develops a life-threatening arrhythmia or irreversible renal failure in a situation when you could have intervened sooner.
Thank you. Adam, what do you got? Any idea on the incidence? How common it is? You said all patients come to your floor, but how about on a more global level?
I'd have to Google that. I have no idea. And I'd be lying to you if I gave you a number.
Yeah, because I'll tell you what I've learned so far is that everyone has tumor lysis syndrome, including Haney and I right now.
Right now.
You very well might. In my world, everybody does, to be honest. And if they don't, they're going to get it at some point. It's probably
That's right.
That's right. And my team's fault.
Yeah. You really haven't lived until you've had tumor lysis syndrome, let me tell you. That's great. So you're cast over 10. We consider that your case.
We didn't like that comment. Which
comment? I missed it.
I thought you were going to say it's the Omicron of things, and I was like, no, we can't have that. Just
it's not funny.
It's not funny. Too soon.
Too soon.
Okay.
All right, Haley, you asked a question.
Yeah. So, I mean, one of the benefits about having people on who are experts is that we can really ask them, like, what do we need to know? Every time I work a shift in the emergency room and I see Matt Salzman, who's one of our toxicologists, I always pull him aside, like, what's my tox pearl for the day? Teach me something. So to you, I ask you, what is like something new and cutting edge that we should know about tumor lysis syndrome? There has to be something. Or maybe not. Maybe it's one of those boring therapies.
I think it's one of those boring things where the treatment has been the same for a long, long time. I think that the biggest thing is make sure that it's on your radar, because in the acute situation, when someone is coming in, especially if they're coming into the critical care unit, you're very worried about their respiratory status, their cardiac status, their blood pressure, of course. But this has been missed, and we've had patients who come in with dangerously low blood counts or dangerously high blood counts, and everybody was so focused on other things that were happening, and then a day or so later they say, oh, whoops, this person has some hematologic abnormality, maybe I should call my friend and figure out what's happening here. And then we find out down the line they do have an aggressive hematologic malignancy, and I believe we had a case like that fairly recently. So I think as long as you keep it on your radar, remember that it exists, know what the criteria are, it will benefit you, because you will every so often pick up a patient and say, oh, something doesn't seem right here, and the lab criteria may fit, and you could save their life.
Got it.
That's great. That's a perfect lead to my favorite question that we ask everyone who comes on. What is one thing that us intensivists do that just drives you crazy? And it doesn't have to be about tumor lysis. It could just be about anything. What is it that we without fail do, and you wish we didn't?
And don't worry, no one's watching this. It's just the three of us.
No. I'm trying to think, because I actually really like you guys. I know that's hard to believe, but I do. I think we work really well together. I could probably name a lot of things that other departments do that drive me crazy, but that wouldn't be nice.
No, kick us and throw dirt on us right now. And it's good, because I find that those types of questions are actually what makes us better, is to know what the things that we are not attuned to, or something we should be taking more seriously that we're not.
I could go first if you want me to. I can tell you something that the oncologists do that drives me nuts.
I have an idea, but I don't know that it's you guys in particular.
This is what drives me nuts. When I'm called at 3 a.m. to put a dialysis catheter in for someone who might get exchange transfusion tomorrow. and I say it takes the New York Blood Exchange hours to show up. It takes me 18 minutes to put a catheter in. You let me know when they're in the driveway, then I'll come and do it.
They won't drive from New York until that catheter is in, so they won't even start their 2-hour departure. But you're right, that is really
now. I think Danielle's going to find something. I think you got her going now.
Just tell them it's in. What are we doing here?
Well, we don't really have scattered bed hospice right now, but when patients are put on comfort care and come out of the unit and there hasn't been a hospice discussion, drives me insane. So it depends on the time of day, of course. It depends on who's on service. Sometimes it's the residents and fellows, so I always try to re-educate them about the benefits of those things. But that's one thing that I think we could probably do a little better.
Let me ask you.
Go ahead. Let me say one quick thing about that, then I'll let you.
Please.
In a former life, I was a pulmonary fellow, and I remember having patients with end-stage COPD come into my office when they're at their best. And they're going to their grandkids' soccer game, they're happy, they have quality of life, and that picture would stick with me. And then they would show up in an exacerbation huffing and puffing, and the critical care fellow would look at him and say, this guy should be comfort, he should be hospice. And it used to drive me nuts that they were making a decision on how they were at their worst and not considering the overall picture. And so, I think that's what you're saying too, is that I know you're saying hospice, but I try to always get you guys involved if it's a patient you guys have known long term, because it's unfair for me to judge them in that acute snapshot.
Right.
Yeah, and I want to build off that, not to pick, but on that note, do you think that, well, let me ask you this. Who do you think is best for the discussion? We're lucky that we work in a place that we have a really good palliative care department, right? Not everyone does, so sometimes it has to be a service-specific discussion. But who do you feel is best tuned or dialed in at a place that has palliative care to have these discussions? Do you feel like it's the Heme/Onc team because they've had a relationship with the patient? They've had hopefully some of these discussions leading up to this, if it's a known diagnosis. Do you think it's B, the critical care service that's acutely dealing with this person that kind of has a sense for the acute mortality of this person? Do you think C, is it palliative care because it becomes neutral and objective? There's no emotions that are mixed in, which can happen sometimes, especially with long-standing patients. Or do you think, the classic, it's a multidisciplinary approach, it should be everybody? Because that's always the right answer, but in reality...
Right. In an ideal world, it should be everybody, but that can't always happen. I just had this conversation with my medical students today because I'm one of the co-course directors for ICCC, and it's all about the biopsychosocial aspects of cancer care, my pillar. And it's all about having hard conversations, and it's about having the courage as the provider to start those conversations, to be able to break bad news, to be able to be with the family and tell people, if they're at the end of their life. And so I think in general, we can do a better job of training our residents and fellows on how to have these conversations. My favorite phrase is that you don't need palliative care to make people end of life. And you don't get good at those discussions unless you have them and you learn how to do them. So, I really think it depends, to be honest, on the situation, who's available, and really what's going on with the patient. We've had patients come in who have an incurable cancer, for example, metastatic breast cancer to the bone, and their survival is on the order of years because they're on hormone therapy and they've been doing great, but they're dying of heart failure or they're dying of some sort of pulmonary infection. And while we can weigh in a little bit, the cancer is not really driving their end-of-life process. And so at those times, I think it's very important for the other service lines to be able to help us with that and explain exactly what's happening with whatever organ is failing and, what we think the odds are of meaningful recovery, and do we think the person is going to survive the event. But it's not always the cancer, believe it or not. And we do, I had a patient recently with lung cancer who had critical coronary artery disease and needed a CABG, and the lung cancer was curable. The prognosis from her heart disease was 3 months. The prognosis from her cancer was curable. So we had to meet as a team and decide, was this person going to go for a CABG, which she ultimately did. And it's not common, but it happens that, the prognosis from the cancer is better than whatever else is going on.
Yeah, that's one thing that I think we can all do better by. And we did it for a little bit of time where we had these rounds that would happen in the unit for, when we had a high census of patients that had malignancy, that it's one thing to just sort of operate through the fellows or operate through notes. But for things like this, where, you have a perspective as the oncologist and I have a perspective as the intensivist to come down and look at the data side by side and saying like, okay, like you said, the cancer might be beatable, but we're not going to get through this episode right here. There's respiratory failure, there's ARDS. And so bringing everyone on the same page anytime you can. I mean, not just this discussion, but anything in medicine is really good. So I encourage people to get people in the room, even if it's once a week, to sit down and go through the census and figure out some things, possibly even more frequent. But it really is a game changer. And I'm, as I get more mature in medicine, I realize how important it is to really sit down and interface with people, not just like, call the fellow, who's like taking a billion other phone calls and just gonna, sometimes just give you the answer that's the path of least resistance.
Haney, I still tell the story of the patient that you and I had, who was a young gentleman with testicular cancer, and he was taken for an EGD and aspirated. I know you remember this case. and he went into florid shock and was on 4 pressors, had to be prone. And we flipped him over the next day, which happened to be his birthday. And I said, my window of opportunity is about this much to give the chemo. And you looked at me like I was crazy. And we did it, and he trusted me, and we got him off the vent, and we got him into remission, including his brain metastasis. And, he lived to tell. Again, if we hadn't have had that conversation, we could have missed an opportunity to save that person's life. And I am very big, and why we get along so well, the 3 of us, I'm very big on old-fashioned, pick up the phone, come face-to-face and have a conversation. I don't believe in dropping notes and not speaking to people. I don't believe in not answering the phone or turfing it. I really think that those conversations where you can hear tone and inflection, you have a better understanding of how acute the situation is, really helps you work together better to help the patients.
Yep, that's a perfect example that I remember so vividly where we had the discussion. And yes, I did think you were crazy when you first said it, but because the guy was so sick. But when I looked at you and we talked and you said this is curable and we looked at data and stuff, I was like, yeah, well, this makes perfect sense. And if anyone's going to survive this, it'll be this person because he's sick, but he has this that's curable. But if it wasn't for you and it was through a fellow or a discussion, I can almost guarantee that it's like, well, that's their perspective. That's what oncologists say. They're always optimistic about things.
There's always chemo for everything.
So no, that's a very, very good example. So just get with your specialists in front of them in person, not notes, not through fellows. Sit down and talk to them because, reciprocating the other way, I'm sure there's been situations where the intensivist kind of alludes to things. You're like, oh, I didn't see that angle of it. So it's just always so much better for patients when we're in person.
I agree.
Mm-hmm. Adam, you got anything else? I'm going to scan for any questions in the audience.
I just realized I've been reading the questions I wrote and that you had an entire different list of questions, which I completely ignored, but I think we hit them all.
I was going to ask Danielle where she gets her hair done because it looks phenomenal today.
Oh, I just got it. Thank you. I just got it done at Sequoia in Collingswood. Billy Joe is amazing.
Shout out to that. Yeah, that's where we are. I'm right here in Collingswood. I'll pass by and maybe I'll get the roots touched up or something.
You could get them touched up. She does a fabulous job and she's not expensive.
Handy, that's a little bit of a burn because in our pre-show, I told you that I've been growing a beard for the last several months.
Yeah.
And I asked you to comment. And you chose to not comment on my wonderful manly beard and instead compliment Danielle on her.
Well, now I want to see this manly beard because I can't see you, Adam.
Yeah. Well,
with the mask, you can't see anybody.
Yeah, it's something.
It is something. It's very subtle. It's just kind of like there. It's like, it's nice. It's nice.
Yeah, it looks thicker than it is because it's so thin on top. So that, I have that advantage. Hey, look, we have a question.
Ooh.
Do we now?
The question is, can I answer it?
Okay. So Awab Khan asks, are there any risk factors or lab markers we can look out for as residents to help us determine if a patient will have a higher likelihood of developing tumor lysis syndrome?
So I think a baseline uric acid is really important. The uric acid level can be incredibly elevated before you start to see the effects on the kidneys. So baseline uric acid is incredibly important. And I think also being mindful of the patients that do have high tumor burdens, because even if it's not a hematologic malignancy, solid tumor patients are also going to be at risk.
Look at that. I just learned how to do this. I could have just put that and not read the whole question.
Oh.
I'm a lifelong learner, just so you know. Let's see. I think those are the questions that we have for now. Danielle, any parting thoughts before we let you go? I know you're super busy. We don't want to keep you too long, but we appreciate you being here.
No, I think, part of what I love about Cooper and why I stayed for so long is the people that you get to work with. And I think that the connections that you make with your colleagues really make or break your job. And I push this to the students all the time too. Get to know the people that you work with, from the nursing staff, the janitorial staff, the housekeeping, the food service people, the attendings, the residents, the fellows. Everybody has a role and everybody helps make the day go by. And you never know. You meet the same people on the way up as you do on the way down. So I think that part of what makes Cooper's so unique is that we have personal connections with each other outside of patient care. So we stop and have a cup of coffee. We talk about our families. We talk about our kids. We talk about our dogs. Thankfully, my dog has been very quiet. We get to know each other on a personal level, and it really helps in those stressful situations. It helps in the really sad situations, and it helps in the times that you get to celebrate. So I think that's my parting bit is get to know and love the people that you work with.
That is so true. And when people ask me, where should I train? Or what attending job should I take? This one's offering more money. I have to say that it always comes back to where did you feel the most natural? Where did you feel at home? And I'd gladly trade in a couple $1,000s if I could like to go to work every day versus a place that's paying me a lot of money where I really can't stand anybody. So that's really good advice.
Absolutely.
We have one more question. Watch that. Boom. Randy, who is pivotal in our audio prowess today, asks. It's kind of an inside joke, but that's not even joke is probably too much of an overstatement. A patient comes in critically ill and happens to also have smoldering liquid tumor, say CLL. White count is 170. What risk factors do we need to check baseline tumor lysis labs? Did I ask? What are risk factors do we need to check baseline tumor lysis labs?
So in diseases that are more chronic, the CMLs, the CLLs, those patients can have white blood cell counts that get exorbitantly high. I've seen 600,000 to 700,000 in CLL. And you're not concerned because they're mature cells. It's a chronic illness. It's usually very indolent and it grows very slowly. In those patients, I'm less concerned. Now, if you have someone whose white blood cell count is 170,000 and the lab is refusing to release the differential, or they release it and they call it other cells, that's when you need to be concerned. At Cooper, our pathologists have to manually review the blood smears before they will call it blasts on nights and weekends. So the techs will put them in as other cells, or they will not release the differential and they'll say it has to be reviewed. That's when I would be very suspicious and I would make sure that you're calling your hematology oncology on-call person to come in and review, because just about every single time you're dealing with somebody who's in blast crisis of acute leukemia.
Perfect. All right, Adam, anything else? Any closing thoughts?
No, I thought this was great. This was perfect. I really just appreciate your time and dropping some knowledge, and that's I thought it was wonderful.
Thank you so much. I
probably would have done better if I knew the questions, but that's okay.
We never give you the questions.
I know, and it's like, how I forgot about the uric acid because I'm trying to fire stuff off.
No, we really appreciate your time and your expertise, and you've helped a lot of residents, fellows, and junior attendings with this disease. So thank you so much for taking time out of your day, and I'll tell them down the road that you sent me down for my roots. So I appreciate that. Have a great night.
Good night.
You got anything else, Adam?
Yeah, I was going to say I'm reading a question about steroids to reduce TLS. And I have an easy answer. They're already on steroids. Everyone has COVID.
Well, so steroids are not going to reduce tumor lysis. If anything, they're going to promote tumor lysis, especially in your hematologic malignancies. So your high-grade lymphomas, steroids are incredibly active, and one dose of steroids can put you into florid tumor lysis. So when you're adding steroids, if their lab abnormalities are getting worse and they have bulky adenopathy, think tumor lysis.
All right.
I'm glad I asked that. Thank you.
No problem.
All right.
With that said,
we'll have a great night, Danielle. We'll see you around the hospital.
All right. You take care, guys. Thanks.
See you later.
Bye.
All right, my man. Episode number 7 in the books.
We did it.
New studio, new setup. The sound, I think, was right.
I think it was better. I'm interested to find out if the echo was clearly improved, but if it was absent.
You know what they say whenever I podcast with someone and they don't know that I've done podcasts before, they're like, you should get a blanket and throw it over your head and microphone. You'll feel ridiculous, but you'll decrease the echo. I don't know if that would look good for video, but I'm just saying, next time if you do a blanket over your head, that might be a little bit of a hoot.
And it'll be warm.
Exactly right. Well, we will definitely keep this cadence up every 2 weeks. That's our New Year's resolution, to make sure we bring you every 2 weeks. We're going to be doing something, whether we have a guest or not. We're going to keep up this pace. So don't make me do the math right now, but I think it'll be the first week in February would be the next Critical Care Lounge. And we'll be sure to let you know who the guest is and what's happening. Or I didn't tell Adam this, but I want to start bringing people on verbally. If they want to, they can call in and ask questions. We have that feature as well. I don't know how many people are going to do it, but if you want to call in and hear your own voice, we're also happy to have you on here as well. And then eventually, we'll actually have people in a studio where we can sit down and hang out. I think that'll be a lot of fun.
I have a feeling Randy S. will be calling in.
I so want to meet this Randy. I know you know him, but I know him by proxy. He sounds like a character.
Careful what you wish for, my friend.
Okay, good to know.
All right,
people. It was really nice to have you here. Thank you so much for joining. If you're still around, please like the video, subscribe to the channel. We're almost at 10,000 subscribers, but most importantly, when you like and subscribe, you keep getting content like this over and over again. And we're very grateful for all of you that keep watching and send all the nice notes in emails and on social media. So we really thank you for the following, and we can't wait to keep bringing more education every single month. All right. Adam, be well.
Be safe.
I'll see you soon. Take care.